This was 20 weeks, borderline ventriculomegaly, shown by ultrasound examination. That was the only significant finding. 9 months postnatal follow-up. You can see a Chiari-1 malformation, ventriculomegaly still there. We, of course, may have difficulties in providing a pathophysiological interpretation, like going from prenatal to postnatal life. There was a variation in skull volume related to the posterior fossa. This has been extensively studied. There are two fundamental publications on this aspect. We haven't done it yet, but we could make a comparison between fetuses that will later on develop the Chiari-1 malformation with normal fetuses that will not progress into Chiari-1, in order to understand whether this volume discrepancy is important or not. We can use linear measurements. This is the fetus that develops Chiari-1 malformation. This is the angle. This is the angle that we're interested in. The closer we get to 90 degrees with a more vertical tentorium, we have a Chiari-1. So we have a smaller fossa, the more vertical the tentorium line. So you can see that these observations have no statistical significance. Chiari-2 is more simple and more difficult to diagnose. We can state that MRI is not necessary for intrauterine Chiari-2 malformation. Ultrasound examination is enough. MRI is used and applied at centers where intrauterine surgery of myelomeningocele is performed, especially for follow-up purposes. MRI can provide information on the degree of tonsil displacement, so we can identify this much better with MRI than with ultrasound. This is a mild displacement and a more severe displacement. Of course, this may sound quite banal. We have a small posterior fossa, herniated tonsil, the skull deformation known as the lemon sign, other different forms of seals, meningoseals and spinal dystrophy, and different degrees, and the hydrocephalus, and To go back to a previous observation, let me remind you that in clinical practice, neuroradiologists know that posterior fossa malformations do not always correspond to the spinal dystrophism level and position. We need to understand if there is a CSF leak, because that's the element that has an impact on supratentorial abnormalities. Let me now mention a few interesting points for future research in Chiari-2 malformation. With MRI can provide information on morphology and skull size and cerebral parenchyma, especially the T2-weighted signal or the apparent diffusion coefficient. These two parameters cannot be assessed with ultrasound. When we see a Chiari-2 case, especially with ventriculomegaly, the cerebral parenchyma signal is no longer normal. As in a normal control, there is a hyper T2 with high T2-weighted signal. If we measure the coefficient, we can see that it's considerably increased. This is evident in this small fetus of 23 weeks. We have signal hyperintensity at the parenchyma compared to the healthy control. If we measure the coefficient, we can see it's increased. This is a preliminary study, only 5 cases. We tend to see less and less Chiari-2 cases. The white matter ADC is normally increased compared to healthy controls. Well, we have no certain pathophysiological interpretation, but when we have craniostenosis and venous hypertension, probably due to ventriculomegaly, the interstitial water in the parenchyma of a Chiari-2 patient is increased. There's probably an increase in interstitial water and a lot of wet white matter, if you like, and the ensuing abnormality is increased T2-weighted signal and increased coefficient. This could be a double-edged knife for intrauterine surgeons. This could be in favor of surgery, since the Chiari-2 could have an impact on the normal histogenesis of the cerebral parenchyma. Then we should operate as early as possible to reduce this problem. But you may also say that diagnosis in Chiari-2 cases, we have already have an altered parenchymal signal, and this would create additional problems, so it would actually make the situation worse. So this is a preliminary aspect.